This video is in combination or in conjunction with my post on baseball throwing injuries. Okay, what I'd like to demonstrate here is the positioning where there's the most stress that occurs to the medial side of the elbow. Okay, the medial side of the elbow has what's called the ulnar collateral ligament, and this is mentioned in my post. The most amount of stress that occurs to the UCL is at the point of terminal cocking phase and early acceleration. So go ahead, Matt, and just kind of put yourself in that position where you're about to throw. Okay? So the amount of stress that gets placed on this elbow is due to the fact that it's being torqued into what we call a valgus position right here. So in a sense, you're kind of taking that elbow and that UCL and you're bending it like this. Okay? So if that UCL isn't being protected or if it's not strong enough, it can tear. All right? So, and the article, my post talks about the fact that in isolation, in cadaver studies, that UCL can only take about 32 newtons of force. During the throw, they've calculated it can take up to 35 newtons, and in total, the amount of force that occurs to the inside part of the elbow is up to 65 newtons of force. So where does the extra force come from? Where does the extra strength come from to take the burden off the UCL? That's the big question, okay? And what we pretty much have to realize is that the muscles have to take the brunt of that force. And if they're weakened, if they're bogged down, if they're scarred, if there's some sort of injury to them, it's going to put even more stress on that UCL. Okay? So what I want to show you in this video is how we actually treat the forearm here at OrthoWell Physical Therapy. So the idea of, I guess impending stress and impending problems with the elbow is the fact that the pitcher might start to complain of just stiffness or soreness in his forearm, and that's like. And that's a warning sign. It's the fact that we've got to get in there. We've got to start working with that tissue to try to break things down. Okay, realize that the pitch is one of the fastest known human motions, 7,000 degrees per second. That's pretty quick. So all that stress on the shoulder, on the elbow, on the forearm, we've got to make sure we get in there and break up these restrictions as the micro trauma occurs, and try to keep things keep ahead of the curve, sort of thing. So no pun intended for curveball. I still got it. Okay, so a little Graston technique to begin with. All right, so there's a lot of different strokes. We have actually about 12 different strokes to choose from when it comes to the Graston technique. I'll just kneel down here beside you. So essentially, we're going to use GT5 here. And we initially want to get in there and just do some scanning. We want to just kind of get a feel for where the most restrictions are occurring in the anterior forearm. So essentially, when we're scanning, we're trying to find those points of fibrosis or kind of a grittiness, kind of a sandpaper-like sensation that reverberates through the instrument. And so we scan through here, through there. We scan from distal to proximal, as well as from proximal to distal. You can see already how he's getting some redness in here just by simply scanning him through here. Okay, so when we isolate, say we pretty much right in the belly of the Pronator Teres muscle. The Pronator muscle is what turns the forearm down. Okay, so there's a restriction right through here. So we'll get in here and we'll sweep through this area. I'll use the softer part of my instrument initially, and then progress to using more of the sharper side. Okay, and we can do some fanning through here. Back and forth. Okay, and already you can see the petechiae occurring in here. And then we can also go from, like I said, from distal to proximal, as well proximal to distal, all the way down through. Okay, we can actually, that's more a static treatment. If we're just treating the Pronator Teres through here, we can also start to add, Matt, I just want you to just kind of pump your wrist up and down. And get right on that spot and just kind of swivel on there as he's dynamically moving that tissue through, the pressure of the instrument. And so this is more of a dynamic release of your Pronator Teres. Okay, and then let's have you hold up here. Okay, then as I move and stroke this through, I want you just to kind of extend your wrist. Okay, and then down. Okay, this is a pin and stretch technique. And back up, back down, all the way through. Good. Then we can do same idea, Matt. Back up again. Now pin and glide. Okay, all the way through and push, and there. Good. Back up and down. Okay. And again. Okay, and at the attachment site, I'll have them just keep on bending up and down. I'll get in here and just do some stroking through the attachment site. And of course, all this is dictated by what I find when I scan the area and I screen it for restrictions. I might treat 30 seconds here, 30 seconds here, 30 seconds over here, and maybe even up into this area as well. You know, you've got your median nerve that comes coursing down through here, your brachialis, your biceps brachii, as well as the other deeper forearm muscles in there as well. So I'll start with the Graston to bring in circulation, initially break things up, desensitize the tissue, and we'll clean them off real good, and get in here and do some ART. Okay, so ART essentially we want to slacken the tissues first. If we're actually going to treat, say, the Pronator Teres again, Pronator from here all the way down into the forearm, crosses your elbow joint, and then it comes in and attaches into your forearm. Okay, so essentially we're going to hold them up like this. Okay, his elbow or wrist position doesn't really matter for the Pronator Teres, so we're going to turn them into pronation, slacken it, flex the elbow to slacken it. I'm going to pretty much put my hand at the point of restriction. All right, I'm going to actually hold that lesion back as I allow the other tissues underneath it to glide through and underneath the Pronator Teres. So I'm actually going to be incorporating maybe some extension here just to kind of pull the flexor digitorum muscles through and underneath the Pronator Teres. Okay? If I'm just treating the pronator, you don't have to worry so much about the wrist. Okay? So up and through, and let's have you hold up there for me. So you can do it either passively or actively, depends on the comfort of the patient. Okay? And let's have you maybe start a little bit more turned down like this. Okay? And let's have you open like this, and then extend your elbow all the way down. And good. And back up. And the wrist, like I said, just for pronator, doesn't matter. Just keep your wrist neutral. And back up. Okay? And back down. All the way down through. Okay. If you want to hit the flexor digitorum superficialis muscle, maybe the muscle belly feels restricted right through here. Same idea. It actually attaches in across the elbow joint, and then also the tendons come down and cross the wrist joint. So it's actually a two joint muscle. Okay. So I'm going to treat the belly here. We're going to start up in this position here. No sense in worrying about the pronation or supination. That's not the muscle we're treating. But into elbow flexion with wrist flexion. Okay, let me get my spot. There's my spot I want to treat here. Okay. Okay, up to the slackened position. Take up my tension, and let's have you extend, and then extend your wrist, and all the way through. And then back up. And then again, back down. Back up, and then again, and back through. So I might treat several spots, in the forearm, depending on what muscles are dysfunctional. Not dysfunctional, but are restricted in a sense. All right. So that's the soft tissue intervention. At least one of several things we can do. And then I guess we'll advertise for Mobility Wad here, but Rogue Fitness, Mobility Wad, Kelly Starr's come up with some really cool ideas for treating soft tissue lesions. The idea of using compression in combination with motion to try to break up restrictions. The whole idea of if you can compress an area and keep the muscles a little bit more firmly and securely against the bone as you're moving tissues through it, you create like a flossing effect of the tissues. Okay. Depending on what we're treating, of course, would dictate exactly where we wrap them. So for him, I'd like to cross the elbow joint up in here just to kind of get those higher attachments against the medial epicondyle, and then come down to the middle part of his forearm. Okay. So this goes on pretty dang tight. It's been an interesting situation in our clinic doing this with people, getting people's responses for wrapping them up real tight like this. People kind of give us the "what the heck you doing to me" sort of look. So back and forth. So I'm, like I said, I'm pulling and putting some good tension into this all the way through. Okay. Okay. Same sort of idea. Really yank it up and through. All the way down to the mid forearm. Doing this a little more speedy so we can get this done today. Okay, and then just kind of cinch it in one of the other layers there, and that's pretty much what we have. Okay, so very, strong compression force. It's all really dictated by, the sensitivity of the patient in a sense. But now we're compressing. Okay, we are in a sense pushing circulation up, and we'll talk about that in a second. So we keep the wrap on for maybe 90 seconds or 2 minutes, pretty much to their tolerance point. You don't want them to be in extreme pain. It's going to be uncomfortable when they do this stuff, because then we're going to make them move and perform exercises as they're in this position. So I'm going to actually grab just say, this is a 2-pound weight or something like that. Let's just get it pumping up and down. So we're going to get the flexors involved, and then let's go ahead and stand. You won't do the full 2 minutes here. Turn and face Michelle. And then same idea, maybe you come up like this and then bend back. Boom. So get the elbow involved in the wrist flexors, up and down, all the way through. Maybe even swing it behind you as you do it, up and down, all the way through. And as you go behind, kind of maybe extend your wrist. There you go, up and through, up and through. And then you can take a weight or one of the marathon sticks, put a weight onto it, and just work on pronation and supination, for example. Okay, so the whole idea is to we're mobilizing tissue in combination with compression, and then so you're at your 90-second, 2-minute point. Patient's telling me to get this the heck off my arm because it's really starting to bother me, and so we rip it off, and it's an idea of the flushing of fluid. You're not really going to be able to see too much here because it really wasn't on long enough. But you'll be able to see the fact that there's a blanching effect that's occurring, above and below, or a reddening effect. But you don't want to have it's not a tourniquet. You don't want to be cutting off circulation to the hand. You just want to check it every now and again to make sure that there's blood flow down through there when the band is on there. But like I said, once you take it off, it's this flushing in of circulation to try to jump-start the healing effect through the area. Okay, so we're combining this idea of soft tissue work. He'd be doing some stretches as well for the area. The band to try to create that compression, flossing, and flushing effect. And that's essentially how we treat this. So good luck, and any questions, give us a call. Thanks.